Hi, my name is Chou, and I'm a medical student at Harvard who has worked with mentors and collaborators at UCSF, and I'm grateful for the opportunity to present my work at this year's meeting. This study was funded by NIH R01 grant, and we have no other relevant disclosures. To begin, nursing home residents comprise a frail and dependent population, and in the United States alone, there are over 1.4 million long-term residents. Urinary catheterization is fairly common in this population, with estimates of up to 13% of residents being admitted to facilities with an indwelling catheter in place. Suprapubic tubes are one commonly used catheter for long-term urinary drainage and may be more amenable for catheter care and have lower infection risks compared to urethral catheters. However, their placement requires an invasive procedure, typically under general anesthesia. No studies address whether placement of these catheters are associated with better functionality, cognition, and mortality in this vulnerable population, for which overall there has been little research regarding long-term outcomes. Thus, we sought to analyze these outcomes in this population undergoing SP2 placement, hypothesizing that the procedure would be associated with marked declines in outcomes. To do this, we identified long-term nursing home residents in the United States who underwent SP2 placement from 2014 to 2016. And this was done by using the minimum data set, or MDS, which tracks questionnaire responses for long-term residents on a quarterly basis. Subjects were only included if they had responses from at least 2 completed questionnaires, at least 90 days apart. SP2 placement was then identified using linked Medicare files. Our primary outcomes were 1-year outcomes pertaining to functional status, cognition, and mortality. For functional status, this was measured using the MDS Activities of Daily Living questionnaire. This instrument has scores ranging from 0 to 28, with higher scores corresponding to poor functional status. And for our purposes, a decline in function was defined as at least a 2-point increase in the MDS ADL score. For cognition, this was measured by the brief interview for mental status questionnaire, or BIMS. Here, scores range from 0 to 15, with lower scores corresponding to poorer cognitive function. And for our purposes, we define decline in cognition as at least a 3-point decrease in the BIMS score. And finally, we recorded mortality as well. In addition to standard patient demographics such as age, gender, race, and Charlson Comorbidity Index, we also utilized a claims-based frailty index. This validated instrument generates a score ranging from 0 to 1, with higher scores corresponding to increased frailty. We identified 9,647 subjects during the study period. This cohort had a mean age of around 81 years, and patients were predominantly male and white. The cohort also had a mean Charlson score of 5.5, a mean claims-based frailty index of 0.31, which corresponds to mild frailty. To visualize overall trajectories of functional outcomes, we perform mixed effects spline models of our subjects. To orient you to this figure, time 0 on the x-axis corresponds to time of SP2 placement, and increasing MDS ADL scores on the left correspond to poor functional outcomes. 61% of our subjects met our definition for functional decline over 1 year, and you can see a fairly stable functional status initially that markedly decreases immediately after SP2 placement, up to around 6 months post-operatively, but this never recovers to baseline status, even 12 months after SP2 placement. Mortality was also very common in this population, with 38% of the population dying within 1 year. With regards to cognition, 38% of residents met our definition for decline in BIMS scores. Here, though, the rate of cognitive decline was fairly steady without a clear association with SP2 placement. We also performed multivariable competing risk analyses that accounted for mortality and other patient characteristics to look at risk factors for worsened outcomes. Interestingly, we found that moderate to severe frailty using the claims-based frailty index was associated with significantly increased hazards of decline in both functional status and cognition compared to those who did not meet frailty criteria. Increase in Charlson comorbidity scores, on the other hand, was not significantly associated with decline in functional status, but was only significantly associated with decline in cognition. A major strength of the study included having complete national data for a poorly studied vulnerable population. The retrospective design cannot account for unmeasured confounders, although we did adjust for various patient demographics and baseline status. We also only included those who underwent SP2 placement based on our selection criteria, although this would actually likely bias the subjects towards more robust residents and thus underestimate procedure morbidity. And finally, we had limited clinical data, but we were still able to better gauge patient outcomes using the questionnaires obtained in the minimum data set. In summary, residents had sharper rates of decline in MDS-ADL functional scores that never recovered to baseline, even 12 months post-operatively. Steady rates of cognitive decline were also seen throughout this period, and over a third of patients died within a year of their procedure. Given such poor outcomes with regards to functional and mortality outcomes, we concluded that caution should be used in performing this supposedly minor procedure. Thank you very much for listening to my presentation, and I'm happy to take any questions.